Good afternoon, and welcome to this edition of HDSA and Me, a virtual educational series for the HD community. Over the next several weeks, HDSA and Me will offer thought-provoking seminars and interactive sessions that are brought to you by many of our HDSA Center of Excellence team members. Today, we welcome Dr. Martha Nance, who will talk about caregiving in the COVID era. You can send a question at any time during the presentation. Just click on the chat function in your toolbar, type your question, and hit send. Your question will be answered at the end of the session. This presentation will be available in about a week on the HDSA YouTube channel. On October 1st, HDSA and Me will be discussing preventing falls at home. And October 15th, the series will delve into the role of palliative care in Huntington's disease. You can register for these sessions by going to hdsa.org/HDSA with the ampersand and me. And now a little about our speaker. Dr. Martha Nance is director of the HDSA Center of Excellence at Hennepin County Medical Center in Minneapolis. She leads the center's HD clinical trials and also serves as the medical advisor to the HDSA Minnesota chapter. Dr. Nance is co-author of A Physician's Guide to the Management of Huntington's Disease, 3rd edition, and we are really delighted to have her here with us today. I'll turn the presentation now over to Dr. Nance.
Great. Well, thank you, Deb. It's such a great pleasure. I'm really pleased to be asked to give a presentation to this group. And it's also interesting to me because it's a new presentation. I haven't written a talk before about caregiving in the COVID era. Can you hear me okay? Okay. I need to figure out how to advance the slides. There we go. Okay. So I do want to make the disclaimer that anything that I say here should be taken as general information and not specific advice to you about how you should be managed or the care of your loved one. You should always talk to your own care team about the specifics of your management. And I'm having, so there's a graphic that we put in the, back up one more. Thank you. This is a graphic we put in the Physician's Guide a number of years ago that really suggests that the course of Huntington's disease extends for the whole lifetime. And if you look at the disease milestones and the life milestones, really the awareness of Huntington's disease begins with knowing that your parent has it. Then there are life milestones that take place, like decisions about marriage and reproduction and work and so on. Then somewhere along the line comes the diagnosis of Huntington's disease. And then it's a 15, 17, 12, 20-year course after that. And importantly, even after people move into a long-term care facility, that's not the last 6 months, that's often the last several years. So there's a lot of life to be lived after a diagnosis of Huntington's disease. The red line here shows the stages of Huntington's disease, and on the next slide, Manoli, is a more detailed description of the staging of Huntington's disease. We use a staging system called the Schulson-Fahn Total Functional Capacity Scale, which I kind of like because it pretty much anybody could figure out what their stage is. It's based on things that you know about you or about your loved one, their ability to work, to manage money, to do chores around the home, to do activities of daily living, ADLs as we call them, and then whether you live at home or in long-term care. You can add up the numbers and look at the details. You'll be able to access these slides later if you feel the need to study them in more detail. But just understand that certain issues tend to come up in certain stages. So in stage 1, the issues have to do with just slight changes in a person's ability to work or to multitask or to relationships within a family. And then sometimes the diagnosis comes up in stage 1. Quite often I don't see people until stage 2, which is a time that work is definitely going to be impacted. and a person comes in because they need a diagnosis of Huntington's disease because they need to go out on disability. But once somebody gets diagnosed with Huntington, stage 2 is a good time where you can actually be independent, you could live alone, you could do volunteer work, you could travel. And so it really is a time to cherish and to emphasize during the course of Huntington's. Stage 3 is a big transition time where you move from being pretty much independent to maybe needing a little standby assistance. And boy, by the time you're through with stage 3, when you move to stage 4 and 5, those stages really are suggestive of the need for 24-hour supervision and probably some hands-on care. So the staging I find useful in my clinic because I know that certain issues come up at certain stages, and that it's helpful to sort of plan what's coming in the next year or two. So on the next slide, at our center we have a care team that includes, oh, that's the next slide, darn it. So this talks about the care-defining characteristics of Huntington's disease, which again, I think are important to understand. It is a neurologic disease. It, thank goodness, does not affect the heart and the lungs and the kidneys, but the effects on the nervous system are widespread. So we expect to see problems with movement, trouble with thinking and learning and mental processing, and also to a variable degree, changes in mood and behavior. It is typically an adult onset disease, usually in mid-adulthood, and that's also really important in the challenges in providing care. If the average onset age is something like 40 or 50, that's very different than my typical Parkinson patient or Alzheimer patient who's going to be in their 60s or 70s or even 80s. And it presents additional challenges in caregiving because quite often the person with Huntington's disease is living in a house where there are teenage children at home or a spouse who's working. And how do you provide care to all these people, to the person with Huntington's, while also managing all these other issues? And importantly, if we focus on the sort of average Huntington's patient who is in mid-adulthood, it is important to remember that there are some people with Huntington's disease who do have onset at age 60 or 70 or age 6 or 16. And their needs and challenges may be a little bit different than the sort of average case. It is a chronic disease, but chronic over years to maybe even a couple decades. So there's a lot of living to be done after a diagnosis of Huntington's disease, but it does progress. And I think there should be time in the course of Huntington's to anticipate the changes that are going to come down the road in the next year or the next 5 years. It really shouldn't come as a surprise if somebody with Huntington's disease is no longer working, or if they no longer drive, or if they need somebody to be at home supporting them. And then finally, it's a genetic disease, and it really is quintessentially a family disease. This disease really affects everybody, not just the person who has the CAG repeat expansion. The caregiver may be a child who is worrying as they provide care to a parent that they're sort of looking into the crystal ball. This may be what happens to them down the road, and that may make it difficult for them to provide care. I long ago quit thinking ill of people in HD families who moved far away and said, I really need to live my life as long as I can. But of course that puts more burden on the family members who stayed home. So how do you find that balance? So these to me are the care-defining characteristics of Huntington's. On the next slide, Manelli, we show the team that we have at my Center of Excellence. And the team that you might hope to build, even if you don't have access to a Center of Excellence. We have neurology, neuropsychology, psychology, social work, genetic counselor, physical therapy, occupational therapy, speech therapy, dietitian, research people. And that's not all. Everybody with Huntington's really needs a primary care doctor. They need a dentist. We have medical students and fellows, trainees coming through. We used to have a chaplain, which was actually very nice to have. And having a care manager or nurse coordinator can also be very helpful. It's the whole point of the Center of Excellence program is to have all these people conveniently in one location so that a patient can come and family can come and see all these people fairly efficiently. But even if you are not involved with the Center of Excellence, you can still build your care team. You may just have to be more aggressive and proactive about it. You may have to ask your doctor for a referral to a speech pathologist or to find you a genetic counselor to speak with. So on the next slide, how is anything any different now in the COVID era? And I think the first point I want to make, because people ask, is am I more likely to develop a COVID infection because I have Huntington's, or am I more likely to get a bad infection if I get it because of Huntington's? There has not been any published literature on this, so anybody could only tell you what their own experience is, but my experience has not been of any increased frequency of COVID in my Huntington's patients or more severe COVID infections. Now, obviously, an older person or a later stage patient, somebody who's not ambulatory or who chokes frequently when they're swallowing, these are and can't clear their secretions very well. Those are patients who are probably at a higher risk of having a severe infection. But just because you got diagnosed yesterday with Huntington's disease or because you had a gene test 3 years ago that showed you carry the gene, neither of those things makes you at a higher risk today of having the infection. So on the next slide, what does COVID do? What has changed in the COVID era? There have been all kinds of indirect side effects of COVID-19, and I'm going to bring you down and then hopefully bring you back up. And at the end, I'm hoping that some of the participants will have some ideas of things that they've done or tried that have actually worked or helped or made a difference. But first, let's talk about the bad stuff. What are the bad things that happen because of COVID? The big one is isolation. Isolation from family, isolation from friends, isolation from other communities that you participate in, whether it's a faith community, a work community, your model railroad club, your bowling league. All these things have sort of been put on hold. I actually put neighbors in parentheses because if there's anything that I think maybe we are actually doing more of, we may be seeing more of our neighbors as nobody goes anywhere and we all sort of, try and go for a walk down the block. You might actually see your neighbor over the fence. But isolation has been a huge issue for many of my patients. On the next slide, there's also the medical effects. So at least for a while, medical clinics kind of closed down. And clinics were canceling appointments as they tried to figure out how to provide care safely. Elective procedures were canceled. And now it feels to me like we're kind of having the flip version of that, which is, at least in my center in Minnesota, we are back up and functioning. We do video visits, we do in-person visits, we do telephone visits if we have to. We don't like to, but if that's the only way to reach a patient, we'll do that. But we've had more trouble with the patients canceling appointments and canceling procedures. I think patients are, and or just not calling for an appointment. I think patients may think that clinics are still closed. Now there may be a backlog because things kind of shut down for a couple of months. So you may need to be persistent. You may need to advocate for yourself to say, I need to get in and be aggressive about it. But the clinics are up and running again. Now, on the next slide, another side effect of COVID-19 is, well, the couch potato syndrome. So we are all less physically active, and I'll raise my hand and say, me too. I have been less physically active. The gyms are closed. The classes that you used to go to are canceled. Social distancing may prevent you from doing certain kinds of activities. You know, if you've got Huntington's disease and you sit on the sofa for 6 months, guess what's going to happen? You're going to get worse. You're going to be less able to move. Your balance is going to be worse. Your movements are going to be more out of control. We have to keep moving. On the next slide, we also have had less cognitive activity. There's no place to go, nothing to do, so you're not planning anything. You're not, you know, reading a book about your upcoming trip to Ireland and where you'd like to go. You're not, and because you're not doing anything, you have no new memories to talk about. I've noticed this even in my own family. My 2 sons are grown up and live on opposite coasts, and we call on the weekend and say, so, hi, how are you? Fine. What did you do all week? Well, we were at home and we did this, and we, you know, going to work from home. And how about you? And I said, well, I went to work and I went home. You know, so there's nothing very exciting to be talking about. And so we are also cognitively less active. And on the next slide, we're also less socially active than we were. Again, no movies, no concerts, no sporting events, no restaurants, no parties. Fewer trips to the store, fewer trips to the hairdresser. I got my license renewed online. People are working from home. You're doing more sort of solo kind of online activities. I think in terms of, there is the flip side of this that has happened with some of my patients, where the family moved the patient into their home. An adult child moved their parent back into the home, or the adult child moved back into the home of the parent, and you're getting a little bit too much family. So, you know, again, there has to be a balance between interacting, but also giving people a little bit of space. And then another side effect of lack of social activity is that there's just no reason to even bother getting out of your jammies in the morning. And so we're just less attentive to you know, trying to look good, or even, and I think when you look good, you feel better. So these are some of the downer things that happen. On the next slide, this can all lead to just kind of this downward spiral. Look at all these awful words: boredom, fear, insecurity, failure, depression, despair, discouragement, guilt, dread, worry, you know, doubt, depression, you know, all these things. Anybody listening feel that any of these words apply to you? Whether you're a person with Huntington's disease, or a caregiver of a person with Huntington's, or a health professional, I think we're all experiencing these kind of bad words. On the next slide, it shows that where there's a downward spiral, there can also be an upward spiral. And what I really would like to do, and the whole point of this, is to help move people more in the upward direction. Let's talk about, how can we be hopeful? How can we think positively? How can we be more confident, even experience joy, empathy, forgiveness, compassion? And I think actually the first piece of that begins with acceptance. I think we all hoped that COVID would kind of blow over, and in a couple of months we go back to life as usual. Unfortunately, that's turning out, well, not to be the case. And we simply have to now go on, to move on. I think in Minnesota, we're all used to sort of hibernating in the winter. So it was pretty easy for all of us to just kind of hunker down for a couple of months. It just felt like winter went on for a couple of months longer. But boy, now it's September, and we really have to figure out, how are we going to go back to living in this new era? So on the next slide, just, you know, to sort of get started, in this time of uncertainty, and this is a time of uncertainty. I mean, quite literally, nobody in the world knows what's going to happen next month, let alone next year. So it is a very uncertain and anxiety-provoking time. Well, when that comes up, you need to take stock of your resources. What are your financial resources? What are your logistical resources? How about your own emotional resources? How about the people near to you, your family, your friends, your community? And then what you really have to do is begin to take control of what you can take control of. There may be all kinds of things that are outside of your control. You're not single-handedly going to stop climate change, or you know, find the vaccine for COVID. But what you can do is eat right. You can drink enough fluids. You can get off the couch and get moving, go for a walk, rest when you need to, and then take your medications correctly. I mean, those are just the very basics. And if you're stuck on those, then don't even bother listening to the rest of the talk. If you don't have access to food, work with your medical team, your social worker, your county caseworker to get access to food. And if you don't have a safe place to live, or you don't have a place to sleep or rest, get access to those very basic things so you can begin to take control of your own life. So on the next slide, I just wanted to talk through, if you are at home, what kinds of things would you do in this new era? And if you're in the early stage of Huntington's disease, you probably don't need a whole lot of caregiving. You may have a care partner, but both of you need to accept that there's going to be a new normal. I think it's good to try to be hopeful, and then say out loud to somebody, what is it that you're hopeful about? What are you hoping for? And let's work on that together. Let's have a goal of something that we can dream of and strive for. Be thankful. Say thank you. Say I love you. You know, as Huntington's progresses, sometimes people can't really talk much anymore, or they have one word or one phrase that they can say. And I always remember one of my dear patients where the last phrase that he was able to say, and he said it 10 million times a day and it drove people crazy. But the last phrase he was able to say is, I love you, I love you, I love you. And that certainly is a better last phrase to say than some of the other alternatives. So practice saying it now, and say it frequently in this difficult time. Cherish your time with family, but you know, you need a little time apart too. Exercise, get outside. I do think that we are safe outside. You're not going to contract COVID walking down an empty street. So go for a walk. Get a dog. My dear husband decided it was a great time to get a dog. And you know what? It probably was, because even for us, we go home after being at work and we're kind of tired and it's really easy to sit on the sofa. But you get a dog and you have to go out for a walk. Give yourself credit. I was kind of doing the A through Z here of things to do. Give yourself credit for the good things you've done. If you actually got up off the sofa today, give yourself a gold star. And then if you get off the sofa twice tomorrow, give yourself 2 gold stars. Give yourself credit. You're doing good things. Pat yourself on the back. Participate in activities. I'm preaching to the choir here. You guys are listening to this lecture, but you know, participate in HD activities or get back into non-HD community activities as things begin to open up. You know, if there are things that interest you, take part. Try something new. What a perfect time to learn Swedish, or, you know, take an online course about Japanese medieval history, or, you know, whatever it is that interests you. Try something new. Do an online yoga class. And please turn off CNN. This idea of just the slow crawl of news, so that a catastrophe gets spread out over hours, days, weeks. I think it really creates much more anxiety. Watch the news once a day and then turn it off. Use technology to connect. This is an easier group to say that to. My Parkinson patients, my older patients, Alzheimer patients, they struggle much more with connecting to the technology. I think for our Huntington's age group, or the people at risk for Huntington's, much easier to get connected to Facebook and, you know, the internet and Instagram and so on. And then kind of a cool thing is volunteer to help somebody else. I have such remarkable people in my Huntington's community who over years, decades, people have managed to reach beyond their own challenges to actually help somebody else. And it's been unbelievably uplifting and I know, inspirational to me to see these people reach out and help other people. So on the next slide, what if you're in the middle stages of Huntington's? Well, you know, again, eat right, exercise. And this is really a time you need to start acknowledging that you cannot do HD by yourself. You cannot live alone. in a hut up in the North Woods with Huntington's disease. You need to build a community. You need to connect. And if you're a spouse of somebody with Huntington's disease, the two of you can't do it alone. You need to build a bigger community. You need to build your medical community. And if you're feeling overwhelmed, if you are depressed, if you are anxious to the point that you can't leave home, get help. The medical community is there, HDSA is there. There are resources both online and in person to help you get the help that you need in order to be able to move forward. On the next slide, what do you do in the late stages of Huntington's if you are at home? Again, get help, get help, get help. The more the better. I always think it's better to have more people coming to help out than you could possibly ever need. And then you can say, I don't really need 7 days a week. 6 days a week is enough. So better to have more people volunteering to help than not enough. It can be very helpful to tell your friends or family exactly what you struggle with the most. I had one patient a long time ago. It was a woman with Huntington's. They had teenage kids at home, or maybe a little younger. And the husband was trying to work and manage the kids and manage his wife in the later stages of HD. And what drove him crazy was the washing machine. He didn't know how to use it. It had all these little buttons on it and things you're supposed to turn and push. And the reason he got married is he didn't want to wash clothes. And now he had to figure out this washing machine, and it would just really make him agitated, every week. Well, any mother in the neighborhood could have come over and pushed the on button in 10 seconds and relieved him of hours of anger and stress and annoyance. So if there's something that really drives you nuts, whether it's, preparing meals or cleaning the house or, whatever, tell somebody something specific they can do to help. Get the right equipment. You may need a different kind of toilet or arm rails on the toilet, a different kind of bed, wheelchair, padding for some of the furniture, different utensils, and so on. It's amazing how little things can make all the difference in getting through the day. Forgive yourself for having Huntington's disease. Forgive yourself that you're not a perfect caregiver, and please forgive each other. This is not easy. Neither one of you asked for this, and certainly none of us asked for COVID. You are in this together, and be thankful that you have each other and work together on making your life as good as possible. And I just put palliative care and hospice. These are sort of medical-based services or nursing-based services that are available in some communities. You don't have to go anywhere else to receive palliative care or hospice care. And there are times in your life where one or another of those might be appropriate. So on the next slide, what if your loved one is not at home? I think in some ways that's even harder. It's been very difficult for people to leave their loved one off in the care facility and then not be able to see them for months on end. Get to know the people that are caring for your loved one. Talk to them on the phone. Find out their names. Find out a little bit about them. Know who the Monday nurse is and who the Thursday aide might be. And then help them to know your loved one. Did you know my husband was a big fan of I'm picking on model railroad, or whatever it might be, show jumping horses, whatever it is, help the people who are caring for your loved one to know something special about them. Try to be cordial. This is a tough time for everybody, but you do have to advocate. This is very much like when you have a kid in school. If things don't seem like they're going right for your kid, you don't just sort of say, well, I guess that's just the way it is. You go to your parent-teacher meetings, you meet with people, you talk about what the problem is and try to solve it. And take advantage of every opportunity to interact, whether it's FaceTime or window visits or in-person visits. I think sometimes it's helpful to actually schedule visits so that you know and your loved one knows when to expect a call or a visit. So, it's every Tuesday at 10 or whatever it might be. And then I talked to some of my, the people who really know about late stage care, which is the folks in, we have a nursing home that has a Huntington's unit, and we have a couple of group homes for people with Huntington's disease. And they kind of alternatively said, you know, keeping a routine can be very helpful for the folks in late stage HD, but also they've sort of enjoyed changing things up a little bit. And, you know, the group home really becomes your new home. If the family can't come in and the patient can't go out, then the other folks in that house are your new family for a while. Well, let's change things up. Get your nails done, bring in a wig, bring in silly clothes, you know, do something to kind of lighten things up a little. And I've found it helpful. I have some aging relatives who are a little forgetful, and if you mail pictures or send in a photo album, or if you talk to them, bring the photo album with and kind of go over the, here's that picture when we were traveling to France or whatever it might be. And then make sure you thank the staff. They didn't ask for COVID either. They're working hard in very difficult conditions with being pushed in many different directions. So thank them for the work that they're doing. On the next slide, I'm going to go back to if you're caring for your loved one at home. The next set of slides are actually slides I made for a talk I was giving to doctors and nurses who are taking care of late stage Huntington's folks in a care facility. You are not required to memorize everything on all these slides. I'm not going to read every word on each slide, but the real overall point is that it's complicated. And there's a lot of stuff to think about if you are trying to manage somebody's Huntington's disease at home. One of the disadvantages of having a first floor office is when they're cutting the grass outside. I get the grass cutting. So I'm going to walk as I talk to a different office where it may be quieter. So bear with me as I walk. If we can go to the next slide. So some of the symptoms that we have to treat in Huntington's disease, sort of at any stage, but certainly in the late stages, chorea would be one. Well, how do you manage chorea? As a physician, I tend to treat people with chorea with medications, but there's other things you can do. I often have the occupational therapist help the family look at the environment the person is living in. Are there sharp corners on the edge of the bureau or the coffee table? And by the way, what do you need a coffee table for anyway? Modifying the environment can help protect people against injury due to chorea. And then having a plan for what you do if somebody does experience an injury. These other words, dystonia bullismus, these are other kinds of movement problems. What about walking difficulties? I often get physical therapy involved to assess gait. Would a cane be helpful? Would a walker be helpful? Do you need a wheelchair? And then again, care planning. What do you do if the person falls? If you are the one managing somebody at home, then you are the one that's going to find them on the floor. The only thing worse than the person with Huntington's being on the floor is you trying to pick them up and you both falling down and you both get hurt. So what is the emergency plan? We are in an era now, I really am not as familiar with this as I should be, but HDSA has worked hard on a care packet or a packet of information for first responders. And I think some people are taking advantage of this to actually proactively go to the police department or the fire department and say, I am caring for my loved one in this community. And if I call because they fell, it's because they have this thing called Huntington's disease. They don't necessarily need to go to the emergency room, but you can assess them and can you help me get them up? So it can be very useful if you have somebody in the late stage of Huntington's living at home. It can be very useful to proactively go to the first responders and just inform them and maybe then teach them just a little bit about Huntington's disease. And HDSA has a packet of information that can be very helpful. And I guess there are apps now that can be linked to your phone number. So so if you dial 911, it pops up on their screen that this is a person with Huntington's or with autism or whatever the condition might be. So I would take advantage of those new abilities. And the next slide talks about the what I call the oral motor disorder, and probably the first sentence under the box is the most important one. I always say that sickness and even death in Huntington's disease are often due to what doctors call dysphagia, what patients and families call choking. So swallowing troubles are universal in the late stages of Huntington's disease. The speech pathologist can help assess swallowing, can help the family to make changes in the food textures or the kind of utensils that you use, or just how you sit, how you interact when you eat. We're all used to thinking of meal time as an interactive time, but for some people with Huntington's disease, they really need to focus their attention on eating when they're eating. And so talking while eating or watching TV while eating can actually cause more troubles. You also need to have an opinion about whether you would or would not want the use of a feeding tube at any point. And again, if you're doing this at home, you are the one that's going to be sort of having to recognize these challenges and cobble together your care team or access your care team to help you as problems arise. Now, the next slide talks about the cognitive changes. People with Huntington's disease have difficulty learning new things, new routines, so maintaining a routine can be very helpful. As it's harder for somebody to successfully do stuff, there's a tendency to spend more time sleeping during the day, and then guess what happens at night? Then you're up at night, not very sleepy. Daytime activities can help you to try and maintain a relatively normal day-night sleep-wake schedule. I know for caregivers, this is just really challenging to be, preparing the meals, paying the bills, doing all these things, and being the activities coordinator. That's a perfect activity for the neighbor, the other family member, the church lady. So again, it may be very helpful to have some other person help provide some daytime activities so that you can get other things done while the person with Huntington's is off doing an activity safely. Delayed response times are quite common in Huntington's disease, and I don't have to tell you guys this, but sometimes you ask a question and it takes a minute and a half to get an answer. And that's frustrating if you're in a rush to get someplace. Thank goodness nobody's going anyplace at this point in time. So you have the time to wait a minute and a half for the person to answer. Communication gets to be a problem later in the disease. And I think that's hard as a caregiver when you don't get much communication back. You talk to the person and you either get one word or a short phrase or maybe nothing at all. It feels like you're being cut off. It certainly is not deliberate. It's due to the disease, but it's very hard to, I think, cope with sometimes as a caregiver. On the next slide, everybody wants to talk about behavior issues and psychiatric issues in Huntington's. I can't possibly talk about all these things. I just want to point out a couple. This is a time of great anxiety. And anybody who says they're not anxious is lying. So what do you do for anxiety? Well, medications can sometimes be helpful, but so can mindfulness activities, just learning to bring your stress level down, being more active, doing something else. Sometimes just distraction. If a person is very irritable or upset or anxious, just say, okay, I hear you're upset, let's go get some ice cream. And then they feel better and they're distracted with this other activity. So both medications, but also non-medication approaches can be helpful as you deal with these sort of symptoms. I had one patient I saw just yesterday who is fairly early in the course of Huntington's, has a sister and has two adult children. The one lives at home and I think is 17. The other one is 20 something and not living at home. And this person has occasional explosive episodes. And they have worked hard in their family on what I refer to as Plan B. So yes, there's medications, but there's also let's talk about it now. How are we all going to act if we start to see that behavior, that agitation escalating? And you can even just say, let's go on to plan B. So for the sister, she's able to just tell her sister to go chill out, you go to your room for 15 minutes and we'll talk when you simmer down. So the sister is actually kind of able to talk back to the patient. The adult daughter has moved out of the house, and when she comes and they kind of agitate each other, the adult daughter knows that means it's her time to leave. And for some reason, the younger daughter just is sort of oblivious, is not the one that's getting the brunt of the irritability. So for the three different family members, there are three different sort of plan Bs as to what to do when the person gets upset or agitated. So again, I'm not going to go through all these, but you can think about how, both with medications, but also with environmental strategies to manage some of these behaviors. So on to the next slide. If you are caring for somebody in the late stage of Huntington's disease, you may also be the person who gets up one morning to find that they have a terrible fever, they're not breathing right, their leg is swollen, they fell out of bed and have a broken bone. Suicidality, I put in this list, but actually suicide thinking tends not to occur in the late stages, but somewhat earlier in the course of the disease. But as a care partner, if you guys are at home together more than you used to be, you may be more aware of these things than you used to be when you were working at work and the person with Huntington's was at home all day. So again, make sure that you stay connected with your medical team to know what to do or know who to call if you run into a crisis situation one day. It could happen. And again, if you anticipate it and you say, oh, if there's a fever, if there's changes in respiration, if you fall out of bed, I will call 911. And we've already alerted them that there's somebody with Huntington's disease in this house. So they'll be familiar with that. And then terminal stages happen. We all come to an end at some point. And so recognizing when that's coming, I think, is also important. And the next slide, I just give a couple examples. I'm now in a room where I don't have a clock, so I don't know what time it is. Deb, you or Manili, how much time do I have?
Another 5 or 10 minutes.
Okay. So I just want to give a quick example of a situation. So a 54-year-old man has had Huntington's for 15 years, lives at home, has a wonderful family in terrible Korea. No other real health problems, maybe a little touch of high blood pressure, takes a couple of medicines, antidepressant and a mood stabilizer, but he smokes unsafely, walks unsafely, refuses a wheelchair, falls out of bed, multiple bruises from falling and bumping and hitting things, and he's crashed onto the toilet and broken the toilet multiple times. Well, what do you do about that? Well, on the next slide, next. The doctor would say, well, let's add a drug to reduce the chorea. That's a good idea. Next. And the next one after that. I would get occupational therapy involved to look at the home. What about bed rails? What about toilet? What about the bathtub? What about the kitchen? These are all unsafe places in the house often for people with Huntington's disease. Maybe you pad the floor by the bed. Maybe you pad the walls. Maybe you get a queen size mattress. Chorea is often worse when we put people with Huntington's in a nursing home into a twin size bed. The chorea is often terrible and they fall out of bed. All you have to do for some people is get a queen size mattress and all of a sudden the chorea goes away. Somebody with bad chorea is going to really need a heavy duty recliner, not a little fold up, card table chair to sit in. How about a sort of an industrial or sort of a floor mounted toilet rather than a wall mounted toilet seat? And is there other equipment that would be helpful? And then next. Smoking cessation, we actually had a very successful effort in the care facility. It's harder to do by yourself at home because you have all these pre-existing behavior patterns, but you can make a rule. You do not smoke in bed. You do not smoke while sitting on the sofa. No, no, no. You go outside, you smoke only in the room that's got a stone or brick floor. You have to be safe about these things, and you can make rules about things like smoking. Next. And then I often find that introducing a wheelchair gradually, we do this often in the care facility, you just put it in the corner of the room. And I don't care if you hang the clothes on it or put magazines on it, but then it's there. And on that one bad day, when you really need it, it's there for you. And finally, next, sometimes people behave differently with anybody else in the world besides their spouse and their mother. So just, you know, that's have your nephew come over and go for a walk, and the person may be perfectly happy to go for a walk in the wheelchair with the aide or the nephew, where they're fighting you tooth and nail as a spouse or a parent about using this kind of device. So next. Difficult behavior. Here's a woman in a group home. This is a real case, who's on a few medications. And the story was she gets up every night and pulls all her clothes out of the dresser, gets agitated when the staff tell her to wait till morning. This wakes everybody up and the whole house is awake. What do you do? Next page or next slide. Next. Why is she doing this? Is she incontinent? That's completely different than maybe she wakes up because she thinks it's time to get up. And does this really happen every night, or is it just once in a while? And it feels like it's every night. And in the end, all I had to do is just meet with her before bedtime every night to go through her drawers and set out fresh clothes for tomorrow where she can see them. So if she does wake up, she's able to access clothes and she can see them and doesn't have to wake anybody up. Oh, isn't that cool? Next. And then it's important to recognize, I already kind of said this, it's important to recognize when the end is coming. And I think hospice care can be very helpful. They have a strong focus on comfort, engagement with the family, pain relief, the details of the death process or the service or funeral home, and then support for the family afterwards. Next. So why is it difficult managing somebody with Huntington's at home? Well, these are all the people you might have in a care facility. You have nurses, LPNs, nursing assistants, rehab therapists, social worker, administrators, maintenance, dietitian, cooks, teams of doctors. Next page, or next slide. When you're at home, well, you're doing the job of 20 different people. No wonder it's hard. You also have a pre-existing relationship with the other person that colors how you interact with each other and how you react to each other. And you may also be managing children and working and running the household. This is hard. And none of us are going to be perfect at it. Next slide. So I'm going to show one more story, and then I'd love to hear what's worked for you. On the next slide is my story. So this was a wonderful young man who lived in one of the states that got hit early by COVID. And I got a call from his sister, whose head is off the end of the page there, but he had COVID, was deathly ill, but actually recovered from COVID. But here he was, and they were not allowed to see him. He was in the care facility. Everybody was locked out. He couldn't leave. They couldn't come in. And she ended up writing to everybody she knew in the Huntington's community. This was sort of a colleague who comes from an HD family. And, you know, wrote to everybody in the facility and said, this guy is dying. And the family needs to be able to see him. He's already had COVID, so nobody's going to make him any worse than he is. And if the family can sign disclaimers and so on. And unfortunately, I didn't include the whole picture, which includes the face of the sister, but the look in her eyes and the look in his eyes as they look at each other was just priceless. So, you know, keep advocating to be allowed to see your loved one. And the final slide is 3 months later. Turned out he wasn't dying. All he really needed was family. And here he is with his niece. So, you know, we can get through COVID infections. We can get through terrible, awful times where it seems like there's no hope and the end is coming, and there can be a smile on your face. So I'm done, and I will take questions or comments, and I'm really interested in hearing if people have ideas of things that have worked for them.
Thank you, Martha. That was a terrific presentation. We do have a couple of questions. So let me start with the first one, which is a little bit long. So these folks are in the their family member is in the late stage of Huntington's disease. He's 75, and these folks now have full-time care of him. And they want to know, what are some of the alternative methods for drinking water? He's had multiple urinary tract infections from dehydration because they can't get enough fluids into him. They've tried sippy cups, straws, bottled water. Nothing seems to really do the trick. And are there any different methods geared specifically towards Huntington?
There's not a specific, Huntington's pill to take or treatment, but thickening the liquids sometimes helps. People often have trouble with very thin liquids, and the speech pathologist can do an evaluation of the swallow and make recommendations as to the level of thickness. There's honey thick, and there's nectar thick, and there's pudding thick. The problem with some of the real thickened versions of water is that you don't really get the free water. Another thing is just to do little sips very frequently. Sometimes drinking a whole glass is just going to go down wrong, but taking little sips frequently. This is also a situation where one might think about having a feeding tube, not even necessarily to help with eating so much as getting enough fluid in. And by the way, medications can be given through a feeding tube, and so then you don't have to fight 3 times a day with getting pills down. But the sippy cups and straws, work for some people. And then thickening the liquids would be the other thing that we routinely try.
Another question is, my husband is in the early stages of HD, but I'm having difficulty getting him to wear the mask correctly. It's very irritated when I try to instruct him that it's upside down or under his chin. This results in him getting so frustrated he pulls it off and refuses to participate in whatever we're doing.
Yeah, so this is, I think, there are people who really can't wear a mask very well and people who don't want to wear a mask very well. And there may be kind of a little bit of both often, I think, going on. Do you do something more like a bandana or something more, as we move into winter, you could put on a balaclava, the sort of thing that covers your whole head. Or just keep experimenting with different kinds of masks. There may be certain materials that are easier. Some of them have more of a cone in front of the face that I think is perhaps easier for some people, particularly with beards. Also, the size of the face and the size of the mask make a difference. If you got a big, thick beard, a little tiny mask is not really going to cover things, and it's going to ride up or ride down. I actually personally find that masks that tie up in the back, I like better than a mask that hooks over my ear. So there may be different things you can either rig up yourself and that may help him because it's not going to slide as much when you tie it. There's a tie on the top that goes around your head and a tie on the back that kind of goes around your neck, and that really holds it into place better. So think about rigging up a mask that'll work for him, and then, get his favorite logo on it, whether it's the, New England Patriots or whether it's, I don't know, motorcycle gang, whatever his favorite logo might be. So it's something that sort of speaks to him or speaks for him.
Thank you. So as a caregiver, can you suggest some coping strategies? I'm feeling really overwhelmed.
Yeah. So reach out to anybody. Reach out to HDSA, your national, which has some mental health support available. Reach out to your local group. Reach out to your own physician. You need to carve out time for yourself somehow. If you ever did anybody a favor, if you have any children, have somebody come sit with your loved one for an hour so you can go somewhere, get your hair done, or go do nothing at all. Or they go out of the house and you stay in the house and do nothing at all, or watch your favorite TV show. A lot of times what you really need is is just time alone. And you need to feel that your loved one is safe during that time alone. But take the time to breathe, to exercise, meditation, mindfulness, your favorite music. Any of these things can be helpful for one person or another. But you cannot do it all by yourself. Let somebody help. Bring somebody else into the fold.
Thank you. That was great advice. We do have. Okay, so this is actually a comment. Thank you for doing this. I am 2 years into my caregiver role for my husband, and one of the first things I did was watch your video on YouTube, and I learned so much. You are a blessing to the HD community.
Oh, gee, well, thank you. We are all in this together, and I have to say that my HD families are some of the most inspirational people that I've met in my life, and I am constantly amazed at the resilience and the courage and the strength that people show. And you are not alone. I think anybody who participated on this call today, probably any of the 60 people on the call would happily talk to any of the other 60 people on the call. Connect with each other and let's help each other out in this really difficult time. I see Jimmy Pollard is on the call. Yes, talk to Jimmy Pollard. Thanks, Deb. This is really a pleasure.
Well, thank you all for participating this afternoon. We are out at our time. We'd like to thank Dr. Nance for taking time from her very busy schedule to put together this new presentation on caregiving in the time of COVID. I hope everybody has gotten one or two new nuggets of information and resources from this. And I just want to remind everyone that on October 1st, we'll be discussing preventing falls at home. Thank you, Dr. Nance, again. And if anybody has any questions for Dr. Nance that you did not get a chance to talk about or were too shy to type in, just send it along to hdsainfo@hdsa.org, and we'll send it on to Dr. Nance for her to respond directly to you.
Great.
So have a great day and take care, and see you soon. Bye-bye.
Thanks all of you. Bye-bye.